Thank you. अच्छा. So we'll try to cover every single topic of critical care and relevant articles which are important to remember, studies and numbers. So this will be a little faster. So first is goal directed therapy and the four important articles: reverse trial, process, arise and promise. So when we talk about reverse trial, this was by Professor Emmanuel Rivers in 2000, where the first concept of early goal directed therapy for the treatment of severe sepsis and shock came into the picture. And then three other articles came in 2014. So one was the process trial, then the arise trial from the ANZIC group, and another trial was the promise trial. They all came in the same year, in the same journal itself, right, one after the other, and they looked at the same concept, that what is the actual role of early goal directed therapy and is it really useful in treating these patients. So if you look at this reverse trial, what they looked at, that if you have a CVP of, so the first part was that if you have a CVP of, you look at your CVP, and if it is less than 8 or more than 8, so if it is less than 8, you give your fluid therapy, and if it is more than 8, you look at your blood pressure and you target your MAP of above 65, and if you are able to do that, fine, otherwise add vasoactive agents. You also look at your SCVO2 and you plan your transfusions depending on your SCVO2, and this is how they planned the early goal directed therapy. So they looked at CVP, MAP, SCVO2 and give interventions accordingly. What they found was, in this particular trial, reverse trial one, it was a single center trial. Only one center was there of US. The data was collected over 3 years and the patients enrolled was 263, and the fluid challenge that they gave was 20 to 30, and there was no existing sepsis protocols in this particular study. It was done as per the physician's practice. When we look at the process trial, now the process trial looked at three concepts: the early goal directed therapy as per the reverse protocol, then physician based standard therapy, what the physician felt he should do for such patients, and the usual care where there is no protocol. Here 31 centers were there and roughly around 1300 patients were enrolled, and by this time the surviving sepsis campaign protocols were enrolled, and initially they gave 20 ml per kg as fluid bolus, which was later on changed to a round figure of 1000 ml. Arise protocol, again they compared early goal directed therapy versus control, and where 51 centers, and it was a multinational trial. Again surviving sepsis protocols were enrolled here. And in promise trial, this was a UK based trial, 56 centers were enrolled, 1200 patients were there, and again they looked at 1000 ml as a fluid challenge. So they more or less looked at the same concept, that what is the role of early goal directed therapy versus a standard care, even if you are not following any surviving sepsis protocol. Now if you look at the outcome measures, now this outcome was of the reverse protocol. Apache was more or less similar, 21 versus 20 in the control group, but what they found was that the in-hospital mortality was much lower in the EGDT group, 30.5 versus 46.5, and there was a predicted mortality of less than, minus mortality of 9.6, so roughly 10% reduction in mortality is what they were looking at. And if you look at relative reduction, the percentage was very, very high, and they said that is the reason reverse protocol always said follow the early goal directed therapy. But by that time there were no surviving sepsis protocols. Physicians were probably not so trained to follow a certain practice, and eventually as the practice improved in 2014, when all these three trials came out, they found that whether you are doing early goal directed therapy or your own standard practice, there was hardly any reduction in the mortality. The mortality was more or less same. If you look at the predicted mortality based on Apache 2, 38.2, 37.5, 37.9. Even for arise protocol, nothing different. Even for promise protocol, nothing different. So that is the reason now we don't follow that early goal directed therapy where you measure your CVP, then you map, then look at your SCVO2 and you transfuse your PRBCs. And for in-hospital mortality, a P of 0.52, remember that P of 0.05 is significant. So as per the process trial, as per the arise trial, and as per the promise trial, there was not different. So whether you are doing your early goal directed or you are doing your standard practice, it did not make any difference in the end mortality of these patients. There were a lot of strengths and weaknesses. The early goal directed therapy 90% patient completed this trial. This was as per the reverse protocol, but the biggest weakness was it was a single center study. So whenever we talk about a single centered study, we always look at the bias factor. There is a lot of bias in the data interpretation. The process trial, again, they changed the inclusion criteria from 20 ml per kg to 1000 ml, but otherwise there was good number of trial. ARISE trial is a very large multi-centered trial, and they used the original and EGDT algorithm which was used in the reverse trial. But the problem was they looked at lesser sicker subset. The Apache was around 15 as compared to 20 or 21 in the other trials. So if you talk about early goal directed therapy, the today's message is that various approaches which have been examined by these three latest trials, they suggest that alternative strategies can also provide an equal reduction in mortality as compared to early goal directed therapy. You don't want to walk the tightrope of measuring your CVP, measuring your MAP, and then transfusing blood as per your SCVO2. No, that is not required. You can follow your standard protocol based on your surviving sepsis campaign. Now, what is the role of colloids in the present practice? Lot of articles are there, but the most important ones, one was the SAFE study where they looked at albumin versus saline in resuscitation. Then the VICEP trial where they looked at two aspects, the role of intensive insulin therapy and also the role of pentastarch resuscitation. Then the 6S trial, the Scandinavian trial, where again they compared hydroxyethyl starch versus the Ringer's acetate. Then came the CHEST trial where they looked at again hydroxyethyl starch versus saline. The CRYSTAL trial, again colloids versus crystalloids and mortality in patients with hypervolemic shock, and Albios trial by Professor Jalali Anand where they looked at what is the role of albumin replacement. So they are all colloids. So there were crystalloids versus colloid trial, and these are the ways it was done. They were all multi-centric trials, same BICEP, 6S, CHEST, CRYSTAL, Albios. They were all randomized trials. Most of them were blinded trials and very good number of patients. Almost 5,000, 6,000 patients were enrolled. So there was a good database which they looked at, and the conclusion which was there. The eligibility criteria for almost all trials was they looked at septic patients and they wanted to do fluid resuscitation as a part of intravascular volume expansion, and only adult patients were enrolled in this trial. The primary outcome for all the trials was death at 28 days, and the secondary outcome were other organ failure days like mechanical ventilation, renal replacement, vasopressors, and hospital mortality. In SAFE trial, they compared 4% albumin versus normal saline. In the VICEP trial, there was two parts. One was insulin and the other was fluid. So there was conventional insulin versus the intensive insulin therapy, and Ringer's lactate versus the hetastarch. 6S hetastarch versus Ringer's acetate, what we know as tirofundin. CHEST again saline versus this hetastarch. In CRYSTAL study, they labeled crystalloids and colloids, and they said colloids could be hypooncotic gelatins, 4%, 5% albumin, 20-25% albumin, dextrans, hetastarch. So it was a broader category of crystalloid versus colloid, and Albios was 20% albumin based on the level of the patient's albumin. So they looked at less than 3, 3.5 and so on. They decided what volume of albumin should be given to this patient, and this was compared with crystalloid. So this was the methodology of all these 6 important trials, and the primary outcome, if I look at SAFE trial, right, the death similar, there was no statistical significance in anywhere, 0.87, 0.09, 0.10, so it was more or less similar. There was no statistical significance. The VICEPs trial, again the death was similar whether you gave, now this was about insulin therapy. The only problem in insulin therapy was there was no extra death as compared to intensive insulin therapy versus the conventional insulin therapy. The problem was only about increased incidence of hypoglycemia in the intensive group. When you talk about fluid resuscitation, death at 28 days similar, death at 90 days similar, no statistical significance whether crystalloid was given or colloid was given. As I said, in intensive insulin therapy group, only the incidence of hypoglycemia was very high. Other organ dysfunctions were very high in colloid group when we looked at this trial. So this was the VICEP trial where they looked at renal failure incidence was higher in the hetastarch group as compared to the Ringer's acetate group, and similarly the need for more red cell transfusion was also higher in the hetastarch group. So statistical significance about mortality did not make any difference whether that was insulin or that was fluid therapy. The 6S trial, Here they looked at death, and what they found was that the hetastarch group had a higher death rate as compared to the Ringer's acetate group. Only in this study they found that the mortality was little higher in the colloid group as compared to the crystalloid group. And this was 0.03, statistically significant number. Again, goes against the colloid group per se. The CHESS trial primary outcome 0.26 did not make any difference whether you gave colloids or crystalloids. So that premise of doing fluid resuscitation with colloids so that you don't require that much amount of fluid was not entertained here, and it was found that just by giving colloids you are not reducing mortality. What you are pushing is you are pushing these patients more towards renal failure. The colloid administration led to more incidences of renal failure and more incidences of renal replacement therapy. The serum creatinine was higher in the hetastarch group, and correspondingly the urine output was lower in the hetastarch group, and they were both statistically significant. The survival was similar. There was no effect on mortality. The crystal group, again, death within 28 days was okay, but the 90-day death had a higher incidence in colloid group as compared to the crystalloid group. Albios trial, here albumin was given based on patient's albumin level. What they found was there was no difference in primary outcome, secondary outcome or tertiary outcome in terms of increase in the renal replacement therapy, but there was a trend towards increase in the renal replacement therapy and no difference in mortality. The only difference in mortality what they found was at the time of enrollment, if the patients had septic shock, there was a reduction in 6.3% of mortality in the albumin group versus the non-albumin group, but that subset was very narrow and only patients who had septic shock at the time of enrollment. Lot of strengths and weaknesses, but most of them were large multi-center randomized trials, and here the problem in certain, they also gave open labeled fluid. So apart from the protocol, patients were given certain amounts of crystalloids, and that's the reason they feel that the colloid data was not true, and even the colloid could have been even worse, as an increased in mortality should have been there, but because the patients were given open labeled fluid, so we cannot comment on the mortality. So in the present day, the dictum is the colloids, they do not decrease mortality, but rather they can increase mortality as per couple of studies. It increases the incidence of renal failure, more incidences of renal replacement therapy are there. There are more needs for blood transfusion. No hemodynamic advantage is provided by the colloid resuscitation, and so that is the reason now we do not use colloid for resuscitation in critically ill patients, and now it has been taken over by crystalloids and more so by balanced salt solution. So that is the present evidence regarding colloid. Then what about blood products? When do you transfuse? What do you transfuse? So there are trials. One is the TRIC trial, the very famous TRIC trial 1999, where they looked at what should be the transfusion requirement, and the other was the TRIS trial, where they looked at what should be the hemoglobin threshold when you want to transfuse. So they were both multi-center but open label trial, and almost 7,500 patients were enrolled. So there were two groups. One was the liberal group, where the transfusion was given when the hemoglobin went down below 9, and the other was the conservative group, where the transfusion was given when the HB was less than 7. If you look at the TRIC trial, the mortality 30 days, 60 day ICU, none were different whether you were given restrictive strategy or the liberal strategy, and it also did not increase in the increased incidence of increased hospital stay. So it did not matter whether you gave transfusion at 9 HB or a 7 HB. So what is being followed is a restrictive strategy. You transfuse only when your HB goes down below a particular level, and there was no increased incidence of mortality even with the restrictive strategy. The TRIS trial, similar findings, that a higher threshold did not yield a better advantage. It did not result in reduction in the mortality or any reduction in other organ support, whether that was vasopressor, ventilation, renal replacement. So a lower threshold was equally good as compared to the higher threshold, and they were statistically non-significant, no difference in mortality. Then this was about the threshold. Now the other two trials are about what should be the age of the transfusion. The normal standard blood bank protocol is give the oldest blood, right, which is the oldest in the blood bank will be given first to you, so that age is always maintained. So they looked at what should be the age of the transfused blood in critical ill patients, and this was a random, this is called the ABLE trial. This is randomized trial, and two groups were designed. One received blood transfusion with red cells stored less than 8 days, and the other received blood transfusion as per the protocol of issuing the oldest blood product in the blood bank, which is a standard worldwide protocol that issue the oldest blood in the blood bank. So they looked at, does it make any difference? So when you looked at the outcome, primary outcome, which was death, it did not make any difference, and neither were the secondary outcome. And if you look at the diamond at the bottom, right, on the line of no effect, it is same. So there was no difference whatever is the age of the blood transfusion, and it also did not result in any increased mortality if you are transfusing an old blood. The other was also on the similar lines, which is called the transfuse trial, where again they looked at the age and they divided almost on the similar lines, the freshest blood and the oldest blood. There was no difference in any of the parameters, whether that was mortality or that was secondary outcomes in terms of organ requirements, organ failure support requirements, or patients increased hospital stay, and no difference in mortality. Then what do you do in trauma? The concept came from the proper trial, how you transfuse these patients. So this is 1:1:1 versus 1:1:2 protocol, and this was the trial where they looked at what should be the way in which your blood, your PRBC, FFP and platelets should be transfused, and this knowledge has come from proper trial, and this is the basis of ATLS protocol of 1:1:1. Right, so this was a multi-site randomized trial where they compared the effectiveness and safety of 1:1:1 of plasma platelet PRBC to 1:1:2 protocol, and what they found was there was no difference in mortality. The only difference was you achieve hemostasis faster in 1:1:1 protocol as compared to 1:1:2 protocol. So if you are giving one PRBC, one plasma, one FFP, the hemostasis is achieved faster and patients don't die of exsanguination, but overall mortality did not make any difference. And so they concluded that by following the 1:1 protocol, 1:1:1 protocol, it did not result in significant difference in mortality at 24 hours or at 30 days. However, patients achieved hemostasis and fewer experienced death due to exsanguination by 24, and that's the reason now ATLS is do 1:1:1 protocol. So regarding blood transfusion, restrictive strategy is what a universal policy we do. Unless and until patient is having an active ischemia, we transfuse at a higher level, but otherwise for general critical care patients, 7 HB is what a cutoff is there. No adverse effect about the age of the PRBC. So what the blood bank follows is a standard protocol, and we should respect that protocol. And for plasma platelets PRBC, 1:1:1 does not reduce mortality, but yes, it helps in achieving hemostasis faster. Then the present role of insulin. So the first thing came into picture was the Vandenberg trials, right? So Vandenberg studied 2 trials, one in critical ill and the other in medical ICU. Then the NICE sugar trial, on the basis of which we follow that 180 blood sugar as a cutoff surviving sepsis campaign, came up with that number with the help of the NICE sugar trial, and a recent trial in 2021 where they looked at the controlling study. This is the newer trial which has come into the picture. The Vandenberg trials were single-center trials. Around 2,800 patients were enrolled, and the NICE sugar and the controlling trial were multi-center, and roughly 6,100 in NICE sugar and 22,000 in controlling. So all trials except the latest trial, which is the controlling trial, divided patients into 2 groups. IIT, which is the intensive insulin therapy, where the target was very narrow. You have to keep your blood sugar between 80 to 110, and the conventional group was, if your blood sugar crossed 215, you planned your insulin therapy, and the target was to keep them around 180. The controlling trial divided them into 2 groups, and it divided on the basis of the HbA1c. So if your HbA1c, whatever was the number, plus 15, and if the plan was to keep your sugar levels between 110 to 210, and the standard was to keep it less than 180. So the Vandenberg trial looked at, and what they found was that the conventional therapy group had a higher incidence of mortality as compared to the intensive, but this was the only trial which found that, whether this was in surgical patients or in other patients, and they found that in surgical patients the intensive therapy group had a higher survival as compared to the conventional group. This was the trial, a single center trial, but then it was also studied in medical patients where no major difference was found. In gross group, only in patients who stayed for more than 3 days, they found that the conventional group had a higher mortality as compared to the intensive insulin group. But remember, this was a single center trial, so a lot of bias was expected, and what came out in the picture was next was the NICE sugar. On the basis of the Vandenberg trial, the NICE sugar, a multi-center trial, was carried out, and what they found was, now this was a large trial, and what they found was it did not make any difference whether you are doing an intensive therapy or in terms of overall mortality at 28 days. But when you look at 90-day mortality, the intensive insulin group had a higher mortality as compared to the conventional group, and that is the reason now what Surviving Sepsis also says, keep a blood sugar of around 180. We don't follow the tight 180 to 110 group, and episodes of severe hypoglycemia were very high in the intensive group, 6.8% versus 0.5%, and so we don't follow that 80 to 110 group. Mortality was higher in the IIT group, and overall survival probability did not change, and that's the reason Surviving Sepsis recommends sugars to be less than 180, and NICE sugar and controlling trial also recommends the same, because they did not find any difference in terms of advantage of IIT. Less hypoglycemic events are there, and Vandenberg trials are now not followed since Surviving Sepsis campaign, and so always remember, target your blood sugar to less than 180. Then the role of steroids in critical care. This was the CRASH trial, where they looked at what is the role of steroids in significant head injury, and this was multi-center trial. More than 10,000 patients were enrolled, and they divided the steroids into either patients will receive methylprednisolone or they will receive a placebo. So the dosing was 2 grams of methylprednisolone followed by maintenance dose of 0.5 gram per hour for 48 hours. Many centers still do that, and the death within 2 weeks of therapy was the primary outcome. What they found was that corticosteroids harmed these patients. They did not help these patients. Corticosteroids was causing more harm in terms of whether you were looking at severity of injury, severe, moderate, mild, or the time since when the injury happened. And in overall patients, if you look, the entire diamond is falling towards the corticosteroid worst part. The corticosteroids were not helpful in patients with traumatic brain injury. Then came the Corticus trial by Professor Charles Sprung. So this was, they looked at what is the role of hydrocortisone in septic shock, and most of us still follow that 200 milligrams a day, where you want to give that replacement dose of steroids. And they looked at, is there a clinical evidence of reversal of shock and mortality benefit? What they found was there was no mortality benefit whether you gave steroids or you did not give steroids in different subsets. So this was one subset where there was no response to corticotropin. You gave so they looked at the ACTH test and they found there was no response to steroids. It did not make any difference. Now, even if there was response to this steroid, even if your ACTH test was positive, still there was no difference in mortality whether steroids were given or steroids were not given. Overall patients, again no difference in mortality. The only difference which was there was early reversal of shock in steroid group. There was no difference in mortality. So there are two schools of thought. Some people don't like to give steroids, some people like to, and both are right in terms there is no difference in mortality when we talk about it. The only difference, as I said, was in shock reversal in patients, overall patients, that the patients had a faster shock reversal in groups who received hydrocortisone as compared to the placebo group. Then another very recent trial, adrenal trial, where they looked at what is the role of glucocorticoid in patients with septic shock. 3,800 patients were there, and intention to treat analysis was taken here. 90-day mortality, 28-day mortality, nothing was statistically significant. Similar findings at what Corticus has said. Median time to resolution of shock, it was faster in the corticosteroid group, 0.001% as compared to the non-steroid group. So that's the only advantage of giving steroids, that the shock reversal was little faster as compared to the other parameters. No survival advantage of giving hydrocortisone versus no steroids. Shock reversal, as I said, is statistically significant. No other significant differences, any of the primary or the secondary parameters. Then a recent trial where they looked at, so there are two trials now. This is 2015 trial in JAMA, where they looked at steroids on treatment failure among hospitalized patients with severe CAMP when high inflammatory response. This was multi-center trial. Two groups were divided. One received bolus of 0.5 milligram per kg 12 hours per 12 hours of methylprednisolone or placebo for 5 days, started within 36 hours of hospital admissions, and total patients enrolled were 120. Now remember, this is cap we are talking about. What they found was that the treatment failure was much lower in the methylprednisolone group as compared to the placebo group, but the hospital length of stay, ICU length of stay, in hospital mortality was not different whether patients received steroids or not. So the treatment failure was less, but in overall gross parameters it did not make any difference, and this is what the treatment failure says. We will compare the previous study once again later on. Then came a HYPRESS trial where they looked at effect of hydrocortisone on development of shock among patients with severe sepsis. Similar lines, hydrocortisone was given 50 milligram bolus followed by 200 milligram infusion up to 5 days. Then they started tapering, or the other group was placebo group, and what they found was whether the patients had an intention to treat population or per protocol population, there was no difference in shock reversal. There was no difference in any of the mortality data. This trial did not even say that there was an early shock reversal with the help of steroids, and it did not make any difference whether you are giving steroids or no steroids. This is the latest trial, 2023 March published trial, where they looked at what is the role of hydrocortisone in severe CAP. There we were looking at methylprednisolone. This is hydrocortisone, 200 milligram daily for either 4 to 8 days, followed by a tapering of 8 to 14 days, and the other was a placebo group. 31 French ICUs and 800 odd patients were enrolled, and what they found was that primary outcome, death, at 28 days, it was much lower in hydrocortisone group as compared to a placebo group. So this is the first positive trial of hydrocortisone in community acquired pneumonia, which says if you are giving hydrocortisone, you will have a positive outcome. And what category of patients they enrolled? They enrolled patients who were on mechanical ventilation with a PEEP of 5 and a PF ratio less than 300, patients on HFNC again with a PF ratio of less than 300, or patients on high flow non-rebreather mask with a PF ratio of less than 300, and these are the categories. So not only ventilated, even non-ventilated patients with CAP, adult patients, and severe CAP. So they said that, and this is a recent trial. So if you are giving hydrocortisone, you can have an advantage, a mortality advantage. The first positive trial that has come into the picture now. So steroids in TBI, it actually increases mortality, should not be used. Corticus Adrenal said giving steroids in septic shock only causes early reversal, no mortality advantage. Now in patients with severe CAP, steroid use decreases treatment failure as well as a 28-day mortality. So methylprednisolone said only treatment failure, whereas hydrocortisone is saying that yes, you can actually reduce mortality. And patients with severe sepsis not in shock, steroid did not reduce mortality, and this is as per the HYPRESS trial that it did not reduce. If you are not in shock, Corticus and Adrenal said you are in shock and then I will give steroids. HYPRESS said you are not in shock but I still want to give steroids. It did not help at all. So we have to categorize where you want to actually give steroids and the purpose of giving steroids. Let us look at the role of vasopressors. Very important trial was the VAST trial, where they looked at vasopressin versus norepinephrine. Again a basis of surviving sepsis campaign protocol. Then came the SOAP2 trial, where they looked at dopamine versus norepinephrine, and a VANISH trial where they looked at vasopressin, norepinephrine on kidney failure in patients with shock. So all the three studies compared one vasopressor with the other, and they looked at effect on mortality and AKI, and they were randomized trial, and total patients in the studies were roughly 2800. The VAST trial, they compared norepinephrine to vasopressin, and what they found was there was no difference in 28-day mortality or a 90-day mortality, and there was no difference in ICU or the length of stay. But when they looked at a smaller subgroup, if you are looking at a more sicker subgroup, the vast administration of vasopressin did cause a reduction in the norepinephrine usage, and that's the reason we look at what is the Apache where you want to look at your vasopressin usage. It was statistically non-significant. SOAP2 trial, what they found was that there was no statistical difference in duration of stay or hospital stay or mortality and anything, but dopamine use increased the arrhythmogenicity. There was more incidence of cardiac arrhythmias in dopamine group versus norepinephrine group. The VANISH trial, they looked at vasopressin and norepinephrine, and patients were given either hydrocortisone or placebo, and what they found was there was no major difference in 28-day survival in terms overall incidence and 28-day or ICU mortality. Again, did not help whether you were giving vasopressin or norepinephrine, non-significant. This was sepsis PAM trial where they looked at high end blood pressure. We are not going in that detail. So vasopressin, dopamine, norepinephrine actually does not change any mortality or AKI. They are more or less similar, but still as per the surviving sepsis, we say norepinephrine followed by epinephrine or vasopressin. Cardiac arrhythmias are increased with dopamine administration. Vasopressin only decreased mortality in patients with lesser severe septic shock. Raising the blood pressure in septic shock was not associated with any reduction in mortality. Then a very important, renal, when do you want to dialyze and all that stuff. So two trials, ATN and renal trial. So they looked at what should be the intensity of your renal support in critically ill patients, and both the trials looked at the same thing, and they looked at intensity of renal replacement therapy on mortality and renal recovery, and 2600 patients were enrolled. In ATN they looked at intensive therapy where intermittent hemodialysis or the SLED therapy was done daily for a week, or CRRT was done, so CVV HDF at 35 ml per kg was done, whereas in our renal group a higher intensity was defined as CVV HDF of 40 ml per kg. ATN less intensive was when intermittent dialysis was done thrice weekly, or a CVV HDF of 20 ml per kg, and a low intensity in renal was also almost about the same level. What they found was death, whether from any cause, in hospital, discharge, recovery of kidney function, it did not make any difference whether you are following a higher protocol or a slower protocol in ATN, which was statistically non-significant, whereas in renal again the similar findings were there, that there was no difference in death or renal recovery in any of the patients. So it did not matter whether this was a high intensity group or a low intensity group. Even if you are doing SLED thrice weekly, that should also be enough in terms of renal recovery or mortality. Then when should you initiate these therapies? The other two trials came into the picture, which was EKIKI and the ELAN trial. So the first was what should be the intensity. This is about the timing. When should you initiate, whether early or delayed, and what they defined as early strategy was initiated, RRT was initiated almost at admission, whereas in ELAN it was admitted within 8 hours of KDIGO criteria stage 2, where your urine output is less than 0.5 ml per kg for more than 12 hours, or an absolute rise of creatinine. Whereas the delayed strategy was in EKIKI, RRT only when anuria or oliguria, other indications of a renal replacement therapy are there, whereas in ELAN, it was started within 12 hours of stage 3 AKI, or no initiation was also done. So they said we can even defer dialysis in certain subgroup. What they found in EKIKI, that there was no difference in mortality or renal replacement, dependence on renal replacement therapy, whether you followed an early initiation or you followed a delayed initiation. But the ELAN group said something else. ELAN group said if you are delaying the dialysis, you are causing increase in the mortality. It said the patients will do better if you are starting early during their course of AKI journey, and that's the reason there's a difference in opinion that when should you start, and still we don't have an answer to this. And to answer this, one more study came in 2018, which is the IDEAL ICU trial. In NEGM, this was a major trial which was published, where they looked at what should be the timing of renal replacement therapy. This was done in France. 29 ICUs were there, and the included patients were only who had an criteria F in the rifle criteria. Early initiation was start of RRT within 12 hours of documentation of failure stage, and the delayed was only, it was delayed after 48 hours post diagnosis of failure stage. So 12 hours versus 48 hours is what they were looking at, and obviously for all outcomes we look at 90-day mortality and the secondary outcomes at death and multi-organ failure. What they found was it did not differ whether you are doing early or you are doing delay. There was no difference in mortality and death at day 90 or even at day 28 or day 180. Other organ failure days are also not less, and it did not make any difference even if you're delaying your RRT in these patients. And they concluded that patients with septic shock and acute renal failure, there was no significant difference in overall mortality in 90 days between patients who were administered either an early strategy or who were actually assigned to a delayed strategy. There were strengths and weaknesses. Then Another trial came into the picture because nobody is happy with the results, because everybody wants to do an early dialysis. So START AKI trial came into the picture. They again looked at the same clinical question, 4 trials looking at the same clinical question, that what should be the timing of RRT, and this was again an open label trial. 15 countries, 168 sites were enrolled, and they looked at patients admitted to the ICU with kidney dysfunction, where they defined serum creatinine by a formula that it should be more than 1.47, or an acute renal failure stage 2-3 of KDIGO. So accelerated arm was CRRT within 12 hours, and the control arm was RRT only if you follow certain criteria. Primary outcomes and secondary outcomes were more or less similar, and what they found was it did not make any difference whether you followed an accelerated strategy or a standard strategy in terms of primary outcomes or in terms of any other outcome in these patients. So there was no difference in survival, and they found that if you are doing an accelerated strategy, it did not result in any lower mortality at 90 days. So again, the same answer is coming out, that early initiation is not warranted, that you fix a timeline that as soon as the patient comes, we'll start dialysis within 8 hours or 12 hours. It did not make any difference, and so the intensity also did not make difference, and timing is still questionable. But most of the studies are pointing towards that early initiation is not the ideal choice. Do dialysis when required. Then certain about normal fluids, or I will say a crystalloid kind of fluid. So what should be the fluid? Should it be saline based, or should be the buffered salt solution, or the balanced salt solution? So one was the split trial, where they looked at is there any effect on AKI, and what they found was that there was no increased incidence of AKI in the saline group as compared to the BSS fluid, and again no increase in incidence of mortality. It was statistically non-significant. Similar based, the SMART trial, where we looked at balanced crystalloids versus saline, and again it was 5 ICUs, but in a single center in US this was conducted. And what they found, they divided these patients, balanced crystalloid versus the normal saline group, roughly 8,000 patients in each group. A very, very big trial was taken into account, and they defined a terminology called MAKE 30, major adverse kidney event at 30 days, and death or new requirement of renal replacement therapy. And here they said, if you are using balanced crystalloid solution, there are less incidence of MAKE 30, as in less incidence of renal replacement, renal failure at 30 days as compared to the saline group. But this was the only trial which looked at this number. The rest of the trial said it did not make much of the difference, and they found that there is a lower incidence of composite outcome of death from any cause, new renal replacement therapy. So this trial said that if you are using balanced salt solution, they are better than the saline infusion. Then the PLUS trial, a recent trial, 2022 trial, where again they looked at what should be the role of balanced crystalloid solution in ICU. Again, 53 ICUs in Australia and New Zealand enrolled in this, and they compared Plasma-Lyte versus the 0.9% saline. The primary outcome was death, and the secondary outcome was renal failure days. And what they found was it did not make any difference of death at 90 days whether balanced salt solution was used or any other solution was used, and they were more or less similar in incidence. And they found that it was a heterogeneous population of critically ill patients. We found no evidence that the use of balanced multi-electrolyte solution in preference to saline in ICU resulted in a lower all-cause mortality or risk of acute kidney injury. Again, on the similar lines as the BASICS trial, similarly balanced solution versus 0.9% solution, 75 ICUs in Brazil took part in it, and they gave fluid only to patients who required resuscitation, which was defined by signs of hypoperfusion and one sign of fluid responsiveness. Balanced solution versus 0.9 was compared. Primary outcome was survival, 90-day survival, and the secondary outcome was other organ failure days. And they found was it did not make any difference in mortality whether balanced salt solution was used or any other solution was used. So almost on the similar lines of the PLUS protocol, and they found that it did not significantly reduce the 90-day mortality. Very important trial, classic trial. This was about how much fluid to give to these patients. This was about restriction of intravenous fluids. This is a recent trial, 2022 trial. Again, open label international randomized trial, 31 ICUs in Europe enrolled, and roughly 800 patients in each group were taken into account. The septic shock patients were included as per the sepsis 3 protocol, and they said intervention will be patients should have hypoperfusion, which is defined as lactate of more than 4, MAP of less than 50. Patients should have mottling or a urine output of less than 0.1, and the primary outcome was death at 90 days and secondary outcome was other organ failure days. What they found, it did not make any difference whether you are giving restrictive fluid or more fluid, and again restrictive fluid also did not have other evidence of ischemia. So there was no increased incidence of bowel ischemia, cerebral ischemia, myocardial ischemia, limb ischemia or severe AKI. So by restricting fluids you are not causing harm to your patients. So that feel that let us push fluid to these patients is actually not a good practice, and you can restrict these patients. These patients will not become more and more fluid overloaded, and this is what the overall result said, and this is what that they said restrictive IV fluid was better in overall outcome of these patients as compared to the pushing of fluids. So balanced salt solution did not reduce mortality or need for RRT, and fluid restriction in sepsis also does not result in lower mortality, but it results in it does not increase the incidence of other organ failure days. Thank you.